Native high-resolution T2 weighted images, T2WI, are essential for morphological differentiation of pelvic organ tissue. Contrast-enhanced T1 weighted images, T1WI, give important additional information in almost every problem and should be therefore routinely performed. However, kidney functions, creatinine, should be checked before the intravenous application of contrast media. As intravenous Mr. Contrast agent is gadolinium, GD, based, thyroid function is therefore not required to be checked. In recent years, diffusion-weighted imaging, DWI, gains more attention. This imaging technique was designed to depict alterations in thermally induced random, Brownian motion of water molecules within tissues, and the degree of this motion is known as diffusion. DWI can be performed quickly, without the necessity of contrast IV. The technique yields qualitative and quantitative information about tissue cellularity and cellular membrane integrity. High cellularity and cell membrane integrity restrict water mobility and therefore diffusion, as seen e.g. in tumors. During MR performance, diffusion sensitivity can easily be varied by changing the B value used during image acquisition. Quantitative analysis of diffusion may be performed by obtaining and mapping apparent diffusion coefficient ADC values for the evaluation of inflammation or fistulas. T2WI with fat saturation are helpful, especially with patients where no contrast media application is possible. For the differentiation between hemorrhage or lipid contents, a native T1 weighted sequence without and with fat saturation is helpful. For lymph node detection, a native T1 weighted sequence or proton weighted PD sequence is help. Computed tomography CT with a multi-detector CT, MDCT, the examination of a region of interest can be performed in axial plane in a short examination time with sub-millimeter resolution. The raw data can be post-processed in any plane with approximately the same resolution. It should be noticed that intravenous contrast application is essential for soft tissue contrast, because even CT in venous phase has less tissue contrast compared to native MRI. Before performing contrast-enhanced CT, CECT, kidney function, creatinine, and thyroid function should be checked to be with normal values. Leiomyoma. Leiomyomas have a pseudocapsule, are almost clearly defined and can be located submucosal, growth intraluminal, intramural or subserous, growth to the outside, yet can also be pedunculated. More localizations are cervical, vaginal or intraligamental. Usually, the diagnosis is based on the clinical vaginal examination and ultrasound. In case of myomas large in size or number, a high-resolution MRI of the pelvis may be helpful for the planning of an individual therapy. Hysterectomy, myomectomy, open versus laparoscopic surgery, uterine artery embolization, MR-guided focused ultrasound, or the distinction between benign or malignant appearance. Endometriosis. MRI is recommended in cases with suspicion for subperitoneal endometrioses or in cases with unclear dysmenorrhea and suspicion for adenomyosis. Subperitoneal implants of endometriosis. Subperitoneal implants from endometriosis may be detected with MRI from at least 7 mm in diameter. Endometrial implants are hypointense in native T1WI and T2WI images. Sometimes T1WI hyperintense spots may be present in between the implant if endometriosis is implanted. In the abdominal wall, detection is made with a T1WI sequence with fat saturation. Angulation of the MR sequences to the uterine corpus is essential for correct visualization of the sacrodurine ligament, the torus uterinus and the fornix vaginae. Slice thickness should not exceed 3 to 4 mm for Detection of small implants. There is no indication for CT performance in endometriosis. Adenomyoma/adenomyosis uteri. The adenomyoma and the adenomyosis uteri are two special forms of subperitoneal endometriosis and are located in the myometrium or the junctional zone of the uterus. Areas of endometriosis found within a myoma are defined as adenomyoma. The adenomyoma is almost ovally shaped and slightly blurred around its border with the surrounding myometrium when compared to an intramural leiomyoma. The signal intensity is comparable between both forms of myomas. One distinguishing feature may be the fact that in adenomyoma, the junctional zone is commonly an integral part of the lesion, whereas in leiomyoma, even a small myometrial layer is notable close to the junctional zone. An adenomyosis uteri is characterized by haphazardly scattered endometrial tissue within the uterus wall. Using ultrasound, the adenomyosis uteri often represents heterogeneous and includes microcysts. The accuracy using ultrasound was reported by Bazet et al. With 88%, and a sensitivity of 65%, a specificity of 97.5%, a ppv of 93% and a NPV of 89% when combining transvaginal and transabdominal ultrasound in patients without associated uterine disorders. 18. However, in patients with accompanied uterine disorders, e.g. leiomyomas, or with an enlarged uterus, ultrasound is limited. Incorrect diagnosis of adenomyosis. 18. In those cases, MRI is able to visualize the uterine corpus on its whole extent and free of superimposition. Using MRI, an adenomyosis characteristically shows a thickened junctional zone of more than 12 mm, the norm being max 5 mm, hyperintense spots on T1WI and microcysts. The accuracy using MRI was reported to be 87.5% with a sensitivity of 77.5%, a specificity of 92.5%, a ppv of 84% and a NPV of 89%. Typically, a discrepancy between the anterior and posterior wall of the uterine corpus can also be detected. Differential diagnoses for adenomyoma are leiomyoma or uterine sarcoma. A study by Moghadam et al. Evaluated the predictive value of an preoperative MRI in differentiating between leiomyoma and adenomyosis compared with pathologic findings in 153 women, suggesting that pelvic MRI is highly specific in the diagnosis of adenomyosis with 91% and highly sensitive for leiomyomas with 94%. Fistulas. Vaginal fistulas may commonly occur after surgery, hysterectomy, radiation therapy, or with the background of chronic, inflammatory disease. Surgical reconstruction of such fistulas may be challenging, wherefore the detection and exact location of the fistula is crucial for therapy planning. With thin-sliced T2 weighted or PD images with fat saturation angulated to the vaginal cavity, the fistula presents hyperintense and is commonly well delightable to the surrounding tissue. Patient's preparation with vaginal and rectal filling with ultrasound gel helps to better identify the origin of the fistula. CT is mostly unable to detect small fistulas, why indication is usually not authorized. Symptomatic pelvic floor dysfunction. The prevalence of pelvic organ prolapse in developing countries is reported to be around 19.7%. Vaginal childbirth was demonstrated to be a predictor for levator-une trauma and an increased prevalence of pelvic floor dysfunction, PFD. Even in younger, Paris women. Affected women may suffer from an abnormal frequency and urgency of emptying of the bladder, organ protrusion, pelvic pain, or from dyspareunia, as well as from urinary or fecal incontinence. To evaluate the pelvic floor structures and its integrity, MRI with high-resolution T2 weighted images are performed at rest. This is best done in 3 planes. The dynamic MR scans are performed during straining or defecation in the sagittal plane to evaluate pelvic organ prolapse, POP, and concordant PFD. The radiological report should Give standardized measurements of pelvic organ prolapse, as well as a quantitative description of the pelvic organ position at rest and during straining or evacuation. This precise description gives an impression of an individual woman's pelvic support in addition to an accurate, observer-independent, site-specific observation of the stability or progression of prolapse over time. Similar judgments are made regarding the outcome of surgical repair of prolapse without interpreting the data. Using a grading system, it was shown that the visualization of pelvic organ mobility, the detection of all involved structures and the extent of POP, detached from a grading system based on maximal prolapse values, might have more impact for inter-individual evaluation. Dynamic MRI has benefits especially in regard to women suffering from reprolapse after surgical repair and in the